to respond to that. Because I think you're here mainly for technical, is this doable, is this going to solve some of the needs that you've been hearing about? So I think it's a good segue.
Good afternoon, Chair Greenlink, Vice Chair Thompson, and members of the committee. My name is Don Ross. I'm the Policy and Planning Manager and CCO Contract Admin Manager for the Division of Medical Assistance Programs in the Oregon Health Authority. Our agency participated in this work group and providing technical assistance and information about what implementation of the idea that the group is proposing could work. There aren't any real stories I can share that are better than what the users of the equipment have already shared with you here today. But I would underscore that while they demonstrate that reuse occurs on some level right now with some success, what this group is proposing is that a system be set up to do this on a much larger scale, and with repair and refurbishment and accessorizing that is necessary by trained technicians and assistive technology professionals. Also that an inventory or warehousing and database that all CCOs in the Medicaid delivery system and the agency for the fee-for-service population could go to in order to search and find this equipment and make arrangements for its transportation to wherever the need is at. I also thought it might be useful for the committee to be aware of sort of the size of the spend on these things and the population served. You already know a lot about the Medicaid population. We looked at some 2012 data. We have about approximately 20,000 individuals served in 2012 on the types of equipment that this work group believes could be repurposed. We also have $2.4 million in 2012 spent on the fee-for-service population alone. In 2012, we did not have reliable paid amounts on our managed care encounter data. We are collecting that now, but in 2012 we didn't have that data, but we estimate between 15 and 20 million spent statewide, system-wide per year on these items. And as other folks who have testified already indicated, the equipment is expensive new. It's very expensive, far more expensive than the cost of setting up a system to fix it up and redistribute it to others who have need. The last thing I will add to what you've already heard is that for people whose condition is progressive and changes often, or for children who are developing and growing, their need for the specifics of their equipment can change more often than the coverage criteria allow for replacement of that equipment. So current Medicaid coverage criteria that my agency uses allows for replacement every 5 years, and if an individual is 5 years old, their needs are going to change several times before they turn 10. And this might make that possible so that we could make new or modified equipment available more often without increasing state or federal expenditure on that equipment.